We are going through the HOPS process. HOPS stands for history, observation, palpation, and special test. First, present history. Ask how the athlete thinks they had injured themselves. Ask if the athlete can duplicate what happened on the uninjured knee. Ask them to rate their pain from 1 to 10, and if the pain radiates anywhere else. Ask if they can pinpoint their pain, or did they hear or feel any pops, cracks, snaps, or strict sensations. Now past history. Ask the athlete if they've injured the knee before. If so, how long ago? And if injured, how was it rehabbed or treated? Ask if the athlete is taking any medication or if they have any food or drug allergies.
Now that you have covered the history of the injury, move on to observation. Look for obvious signs of deformity and discoloration, such as redness, bruising, or a blue tint. See if the athlete is holding their knee in a certain way, or if the athlete is walking with a limp. Also look to see if the athlete has any odd facial expressions.
Next, move on to palpating the athlete's knee. Search for palpable gaps, defects, or deformities, as well as any unusual feelings or sensations. First, palpate the bony structures, then the collateral ligaments. Finish by palpating the joint line of the knee. While palpating, ask if the injury point is tender. Notice whether the injury site is warm, hot, or cold. Be sure to palpate the structures of the knee, such as the femur, the tibia, the fibula, head and neck, the condyles and epicondyles, the patella, the tibial tuberosity, Gerdy's tubercle, anterolateral and anteromedial joint line, along with the medial joint line, the medial collateral ligament. Also be sure to palpate muscles such as the biceps femoris, semimembranosus, gracilis, sartorius, gastrocnemius, plantaris, rectus. After you palpate the knee, perform special tests on the athlete to determine specific injuries. Range of motion test. Have the athlete lie face down.
This is so funny. Alright.
Start with the knee extended and have the athlete go through flexion, range of motion, by doing active, passive, and resistive tests.
Alright, active, passive, and resistive.
If the athlete fails either active or passive, do not test resistive ROM. Then have the athlete flex the knee to 90 degrees. Test extension range of motion by doing active, passive, and resistive tests.
Active, passive.
Again, do not test resistive if the athlete has failed either active or passive.
Resistive.
Anterior drawer test. Have the athlete lie down and have the knee at 90 degrees. The examiner should be sitting on the table in front of the athlete with thumbs placed on the patellar tendon. Jerk the knee back and forth. If the joint is too loose, the ACL is injured.
Wouldn't that be painful?
Posterior drawer test. Position the athlete lying down with the knee at 90-degree angle. The examiner should sit on the table in front of the knee. Grab the tibia just below the joint line of the knee with the fingers along the joint line on either side of the patellar tendon. The proximal tibia is pushed posteriorly. If there is a lack of a firm endpoint, there is a sprain to the PCL. Lockman's test. Position the athlete lying down with his or her knee bent at 25 degrees of flexion. Place hand on the tibia around the tuberosity and the other hand on the femur just above the level of the condyles. Jerk the knee up and down. If it moves easily, there is most likely a sprain in the ACL. Valgus stress test. Position the athlete lying on their back with their leg flat. Stand lateral to the athlete with one hand on the medial portion of the distal tibia and the other hand on the lateral joint line. Apply a medial valgus force to the knee while the distal end is moved laterally. If the knee is moved too easily and there is a lack of firm endpoint, there is an injury to the MCL. Also repeat at 25 degrees.
Provide with a roof.
Varus stress test. Have the athlete lie supine with the involved leg close to the edge of the table. The examiner should sit on the table with one hand supporting the lateral portion of the distal tibia, while the other hand holds the knee along the medial joint line. To isolate the LCL, keep the knee flexed at 25 degrees. Apply a lateral varus force to the knee. Repeat at 0 degrees. McMurray's test. Have the athlete lie supine on the table. Examiner should stand lateral and distal to the involved knee. One hand supports the lower leg, while the thumb and index finger on the other hand are positioned in the anteromedial and anterolateral joint line on either side of the patellar tendon. With the tibia maintaining its neutral position, a valgus stress is applied while the knee is flexed through its available range of motion. A varus stress is then applied as the knee is returned to full extension. The examiner internally rotates the tibia and applies a valgus stress while the knee is flexed through its available range of motion. A varus stress is then applied as the knee is returned to full extension. With the tibia externally rotated, the examiner applies a valgus stress while the knee is flexed through its available range of motion. A varus stress is then applied as the knee is returned to full extension. If there are any popping, clicking, or locking sensations in the knee, the athlete has most likely suffered a meniscus lesion. Athlete's compression and distraction test. Position the athlete lying prone on a table with the knee at 90 degrees. Examiner should stand laterally to the involved side. Compression. The examiner applies pressure to the plantar aspect of the heel, applying an axial load to the tibia while simultaneously internally and externally rotating the tibia. Distraction. The examiner grasps the lower leg and stabilizes the knee proximal to the femoral condyles. The tibia is distracted away from the femur, while internally and externally rotating the tibia. Pain during compression that is reduced or eliminated during distraction is indicated of a meniscus tear. Apprehension test. Athlete should lie supine with knee extended.
God. Yes, he does.
Examiner should stand laterally to the involved side. Examiner attempts to move the patella as far laterally as possible without actually dislocating the patella. Laxity of the medial patellar retinaculum or predisposing the athlete to patellar subluxations or dislocations is a sign of patellar subluxation and dislocation.